Assalamu alaikum. Oh, thanks a lot, Dr. Sayed, and I want to thank SSBMT and SSH for the invitation. Of course, thanks Novartis for sponsoring this satellite symposium. So in the next 20 minutes, I will talk about the CAR T cell in relapse refractive diffuse large B-cell lymphoma. So basically, one of the theories that of the relapse of any cancer, that the cancerous cells escape the immune system. So the idea of doing CAR T cells is just to take the T cells, do some manufacturing, reinfuse it to the patient again, so it stimulates the immune system so it can damage the cancerous cells. So why do we need CAR T cell for relapse diffuse large B-cell lymphoma or refractory? So based on the Scholar 1 study, the patient with diffuse large B-cell lymphoma who failed one line of therapy, the overall response rate is about around 36%, with CR around 7%, 2 years overall survival around 20%. For that reason, we need the CAR T cell. So I think you had this graph before. So basically, what is the journey of the patient with for the CAR T cell? First, we'll do the apheresis. You will collect the T cells. Then you'll send it for manufacturing and processing. During that period, which usually take around 3 to 4 weeks, the patient maybe needs bridge therapy just to keep his disease stable, under control. So after that, the patient will receive lymphodepletion, which usually cyclophosphamide and fludarabine. After that, he will continue hospitalization just after the infusion, just to be sure there is no acute toxicity. Then the patient will be discharged. So what are the approved CAR T cell therapy in case of relapse refractory diffuse large B-cell lymphoma? As you can see, we have like 3 approved drugs for the relapse refractory diffuse large B-cell lymphoma. The first one is the T-cell, which are actually, as you heard in the previous lecture, it was approved also for ALL, which is the JED trial. The second product, which is the Axi-cell. The third product, which is the Loso-cell. So as you can see here, for the first product, which is the T-cell, which is under JED trial, Axi-cell, Zoma-1 trial, and the Loso-cell and the Transcend trial. And the approval, all the 3 medications are FDA approved, and the first, the T-cell and Axi-cell, also EMA approved. So what are regarding the manufacturing the cell or leukapheresis? So the advantage of T-cell that if you can do cryopreserve the cells, so you can do the process later. But in case of Axi-cell and Loso-cell, should be a fresh product. Conditioning, as mentioned, usually you give cyclophosphamide and fludarabine. And regarding the CNS disease, regarding the T-cell and Axi-cell, they excluded any patient with CNS disease. In the Loso-cell, they included the secondary CNS, the patient with CNS involvement. So what about the outcome? As you can see, regarding the JED trial, the overall response rate around 52%, with the CR rate around 40%. In case of Zoma trial, overall response rate around 82%, CR around 54%, in the Transcend around the overall response rate 73%, and the CR rate around 53%. So what the update about JED trial? So this is like a 5 years follow-up. So as you can see, the overall response rate around 58%, the CR rate around 46%. And the median progression-free survival around almost 6 months. And at 5 years, 31% of the patients stay disease-free. What about Zoma trial? This is a 4 years update. So its overall response rate around almost 83%, CR rate 58%, median follow-up around 51 months, and 4 years overall survival around 44%. So the important thing now, what are the predictor factors about the outcome? So we'll start one by one. So what about the age? So as you can see in both graphs, actually this is the cut limit was the age 65. So the patient, if the patient age is above 65 or below, you can see there is the p-value wasn't significant in both groups. either in overall survival and progression-free survival, which is not like in case of allogenic stem cell transplant, the age usually is a factor to predict the outcome. So age is not a factor to predict the outcome of the CAR T cell, and there is no upper limit of the age. The most important thing is the performance for the patients. So as you can see, the blue, actually the green blue, which is represent the patient with ECOG 0 to 1. The red line represents the patient with ECOG more than 2. So you can see the difference between the progression-free survival and overall survival with p-value significant. So ECOG can predict, ECOG status of the patient can predict the outcome. What are the predictor factors? So at the time of collection or leukapheresis, multivariate analysis identified that elevated LDH and ECOG affect the outcome. At the time of the infusion of the T cells, actually if the patient has 2 extra nodal size or more, increase in CRP or high metabolic volume at time of treatment, it indicates poor outcome. And actually there is a risk model. So based on how many nodal size, so if the patient has extra nodal size 2 or more, or the patient has high metabolic volume above 80, so if the patient doesn't have any of them, will score 0. If you have one factor, score 1. If you have both, they will score 2. You can see the difference. So the green, the patient without any factors, you can see the progression-free survival and overall survival is better if the patient doesn't have any of these factors with significant p-value. One important factor is the early referral of the patient if you think that he is like a candidate for CAR T cell. As you can see, with the response rate decline with based on the number of previous cycles. So you can see in the first graph, if the patient has 2 lines, the outcome is complete response around 56%, which is decreased if the patient had like 3 lines to 52, 4 lines to around 33. So number of previous line of therapy can predict the outcome. So we talked about the outcome. Now we'll talk about what is the Kkk toxicity with the CAR T cell. Usually, as a physician, we're worried about 2 toxicity, which is usually the cytokine release syndrome and the neurotoxicity. So as you can see, as a compare between 3 trials, CRS around 58% in the T cell, around 93% in the Zoma trial, and on the Transcend around 42%. But when you look at the grade 3 or more, it's around 22% in the JED trial, 13% in Zoma trial, and 2% Transcend. The second toxicity, which is the neurotoxicity, around 21% in the JED, compared to 64% in Zoma and 30% Transcend. Grade 3 or more neurotoxicity at around 12% in JED and around 28% in Zoma and 10% in Transcend. So what are the predictors of increased toxicity? So actually high tumor burden, pre-treatment LDH, and pre-treatment inflammatory markers is predictor of increased toxicity. High peak CAR T cell cytokines level also a factor. Marker of DIC and early CRS or a predictor of increased toxicity. Given that, I mentioned earlier that most of the CNS patient relapse lymphoma with CNS, they were excluded from the trial. Actually, it was published around they include 8 secondary CNS lymphoma patients treated with T-cell. Actually, no patient experienced more than grade 1 neurotoxicity, and no patient required any tocilizumab. And biomarker analysis suggests CAR T-cell expansion despite the absence of systemic disease. Early response assessment demonstrated activity of IV-infused CAR T-cell with CNS space. Although this is 8 patients, but it can give us an idea, maybe the patient with CNS involvement can benefit from CAR T-cell therapy. One important thing is, during the journey of the CAR T-cell is the processing of the cells. So important thing that you have to know which medication should be given or should be avoided before start collecting the cells. because you can see there's a list of medications, and if the patient receives any of them, you need to wait that period before start collecting the cells. This list, you can see here, actually usually deal in case of relapse refractive diffuse large B-cell lymphoma. If the patient failed first salvage, usually like in our center, our protocol to use Bola, Binda, Rituximab. Sometimes it's difficult if we give this patient bendamustine or bolatuzumab, we have to wait around 3 months before collect the cells. So if you plan to start Bola or Benda, better to refer the patient, do the stem cell collection, then the patient receive the bridge therapy. So what is bridging therapy? Actually, the bridging therapy, it's the chemotherapy that you give it to the patient after collecting the stem cells. And the aim of this bridging therapy is not to put the patient in CR, actually just to control the disease. So if the patient doesn't have any bulky disease, he's totally asymptomatic, no need to give him bridging therapy. So indication, rapidly growing lymphoma, bulky disease, systemic symptomatic patient, or major organ involvement, or evidence of, or if the patient expected that the patient there will be delay of the CAR T cell, at that time you can consider bridging therapy. There are multiple bridging therapy like steroid, rituximab, gemcitabine, etoposide, in addition targeted therapy or ibrutinib or radiation. So the bridging therapy, usually you give it to the patient after you collect the stem cells. So will CD19 CAR T cell therapy replaced autotransplant in case of relapse refractive diffuse large B-cell lymphoma? Actually, this abstract was in the last ASH update, so it's phase 3 randomized trial, compare axi-cel versus standard care in patients with relapse refractive diffuse large B-cell lymphoma. So around 359 patients randomized either to receive axi-cel or standard of care. Primary endpoint was event-free survival, which was met with significant p-value. At 24.9 months, it's almost 25 months, median follow-up showed median AFC was with axi-cel around 8 months compared to 2 months standard of care. Overall response rate and CR rate was higher in the axi-cel compared to the standard care, with significant p-value. Median overall survival not reaching the axi-cel around 35 months in the standard of care. Another abstract, which is the T-cell versus standard care as a second-line therapy for primary refractory aggressive B-cell lymphoma, which is the phase 3 Blinda study. As you can see here, they included the patient with age more than 18, history of histological confirmed relapse refractory non-Hodgkin lymphoma within 12 months, and the patient is eligible for stem cell transplant with Kkk 0 to 1, randomized to the arm A, which received just T-cell, or the arm B to receive chemotherapy. Based on the response that will decide whether the patient goes transplant or to receive second or third salvage. Primary endpoint was the AFC. So actually this, like you can see, it's complex. That's why, so no need to go over this slide. It's very complex, but the outcome for this actually trial, there was no difference in AFS between the two arms, between the axi-cel arm and the standard of care. So the conclusion was that T-cell and as a second-line therapy and relapse refractory non-Hodgkin lymphoma didn't have higher AFC compared to the standard of care. So until now, where to fit the CAR T cells? So until now, the standard is when the patient relapse refractory to give salvage. If the patient responds, to go to autologous stem cell transplant. If he failed the first salvage, then you give second salvage. If he responds, to go to autologous stem cell transplant. If he failed, he didn't achieve any, at least partial remission after second salvage, at that time he can go for CAR T cell. So in summary, CD19 CAR T cell approved for chemo-refractory patient diffuse large B-cell lymphoma. Eligibility criteria will be based on center dependent. What are the challenges? One of them, when to refer the patient, was at the time of relapse or if the patient failed first salvage. You know, here in Saudi Arabia, you have King, Dr. Osman, maybe he knows, that you have one center that do CAR T cell, which is King Faisal Special Hospital. So usually we discuss with them, should we refer the refractory disease or if the patient failed first salvage? They answer, once you have relapse or refractory, refer the patient to us, just in case. So the theory of you have something you have to keep in your mind. Some patients who are early relapse or refractory, they are symptomatic. Actually, even if they failed first salvage, they cannot wait until you do the processing of the stem cell. Some of them, unfortunately, they are symptomatic, so you have to give them some medication like bendamustine, bolotuzumab. Cost is a major factor. And of course, the processing time would take like around 3 or 4 weeks, and sometimes the patient cannot wait for that 3 or 4 weeks. Of course, limited centers. I hope in the future I have more than center, and thank you.